So this is actually a patient that I'm actually going to show you her T-scan in a minute, but young lady with cervical cancer. And we actually did, and I'm just going to show you this. I'm putting this down, but let's just talk about this. So this is an Excel sheet. I will send you the link. This is what I'm telling you that you should use no matter whenever you do your brachytherapy. So it literally will have your dose and it calculates your BED and it calculates your EQD2. Okay. So what I did, so this is her first fraction. We got 629 for our HRCTV. We got 417 for the bladder, 278 for the sigmoid. So the rectum is 314 for the sigmoid and 419 for the bowel. So what we do and what you should do is, so this is, we've only done one fraction. So basically what we're going to do, because we will do 5 fractions for her, right? So just to know that are we in this right ballpark, we will actually copy and paste for the next 5 to see where we are. So I've already actually started. I was just kind of already started. So we're going to copy and paste as if we were going to give the same dose, and then you change it whenever you add another dose, right? So we copy and paste and say, we're going to give the same dose for the next 5. Where are we? So if we gave the same dose for the next 5, we would be at 87 for her HRCTV. Her bladder would be at 74. Her rectum is actually not bad at 60, and her sigmoid is at 64, and her bowel's a little bit higher than we would like. So we know that we can change this, but right? So this gives us an idea of where we are. And then the next time what we would do is we keep this sheet and then we'll change the fraction 2 and then we copy and paste and go through. But this should be done for every brachytherapy course patient that you do. This way you know where you are, and it actually calculates. I put my external beam dose here, and if it was different, like there's a patient that I just did where we actually did a nodal boost, and actually all of this was actually 50 gray, so then it would have been a little bit higher. But it calculates this for you, and then you can put it in the chart. And you should just do this for every fraction that you're doing. So any questions about this? From anybody. And we are going to send you a link. It's free. You should just, I mean, this should be an automatic, just win-win. Okay. No questions. Wow. Okay. All right. So let's start with my slide presentation. And actually what I'm going to, oh, wait. We're not going to start with my slide presentation. Sorry. We're not there yet. Sorry. So let's talk about, you guys wanted to talk about and see a patient whose uterus and cervix did not change at all with bladder full and empty. So here's a patient, and this is actually the patient that I showed you the intercavitary on, young girl, and I'm actually going to change this so you can see it. She actually has a retroverted uterus. And so we were worried. So with the retroverted uterus, right, which means, okay, let me just show it to you so that you can see it. With the retroverted uterus, her uterus is actually going backwards. See that right there, right? And you can see it really didn't hurt. This is her bladder empty, right? This is the bladder being full, but if you see it's totally empty. The uterus didn't change. But with the retroverted uterus, you have to be very careful, right? It didn't change. It actually, if you compare it to with the MRI, which I can put as my secondary right now, and make it bigger, you can see even with the MRI, it's really truly retroverted. But the question is, does it stay retroverted? So you can see, look, here's her uterus. It really doesn't change much with bladder filling. It just stays retroverted. But the big question is, will it stay retroverted as the cancer shrinks, right? So we did do daily cone beams because you had to be a little bit careful about this, and it actually never changed. So it stayed retroverted. So it didn't change with bladder filling, and it didn't change with actually the tumor shrinking. And in fact, when we did her first brachytherapy, because this is a dose that I showed you, it stayed retroverted. So I'm going to ask you guys a question, and I think this is very relevant, okay? If it stays backwards, and I know you can't see it very well, but seriously, this is the uterus right here, and you can see the uterus on the CT really well. So here it is, right? You can even see her line of where her tandem would go, right? So if it stays retroverted at the time of brachytherapy, what do? What is the recommendation? If you see it like this, if you're going to do the brachytherapy, what is the recommendation? What should you do? I know it's not a contouring question, but I'm going to ask this because this is relevant anyway. And this is a real case. I mean, this is like the case I just showed you. We just did her on Friday, HDR.
So
anybody?
If anyone wants to answer, they can just raise their hand or open their mic. So Saim, more packing at the posterior side. That's one answer we got from the chat. See, if you have to do more packing at the posterior side.
So what do you do with your tandem though? So when you're going to sound her and when you're going to put your tandem in, do you go straight in? Do you go backwards? How do you put your tandem in?
Flip the tandem.
Yeah, so you put this tandem in backwards. And what you do, and you really should do, is you try to rotate it, right? So if you do have a retroverted uterus at the time of brachytherapy, you put the tandem in backwards, and then you do try to rotate the uterus. And the reason is, if you don't, and if you can see, like she has sigmoid all right here, right? This is sigmoid and rectum. You put the tandem in backwards and you leave it backwards, you really are going to give dose to that. Plus, you're going to give dose to your sacrum, right? So you do try to rotate it. Unfortunately, in this case, she actually had an amazing response, but her uterus really was stuck there, right? And it didn't rotate. And if it didn't, you can treat it, but you got to be very careful about that dose to the sigmoid and the rectum, and the sacrum. But you really should first try to see if you can rotate it. In most cases you can, but in her case we couldn't, right? But in most cases you can, but some you can't. And if you can't, then you do keep it backwards and then you treat. Any questions about this? And then I'm going to show you the next case where the uterus does not change with the bladder filling as well. I mean, there's a lot of cases where the uterus really does not change with bladder filling. So give me 1 second. I'm going to pull it up. It just takes a minute for all these to work. So while I'm doing this, while I'm pulling it up, does anybody have any questions about that? Because I do think it's an interesting case. It's something that you will see, and that's why I brought it up for multiple reasons. I'm not going to get this. Sorry.
It is an interesting case, and I was wondering, do you use an ultrasonography to do your brachytherapy to insert your tandem? Okay.
Yes. Okay, I'm not going to quite get the other case, but I will sorry, I'll do it a different way, but let's just move on and then I'll come back to that since we have, yes, I did. Let's see if I can do this. I'm going to stop sharing for 1 minute, sorry. Okay. Anything else while we're moving forward? Okay, I'm sorry, I am having technical difficulties today, which I normally don't. Sorry about that. We're going to go a different way because I'm having technical difficulties. Okay, can you guys see my slides? Yes?
Yes.
Okay, great. All right, so let's move on to my slides and then we're going to go to contouring. So today we're going to be talking about post-operative pelvic contouring. And key is we're going to actually be talking about both cervical cancer and endometrial cancer. Sorry about that. So let's do our first question. Can we do our first poll question?
Yes.
So the first, okay, ready? So the first poll question is, what is the correct way to contour your vaginal ITV on a CT scan for external beam radiation? Is it A, is it B, is it C, or is it D?
If anyone has problems with their Zoom, you can add your answer on the chat and we will see them.
Okay.
Yes, almost half of our participants and a few ones on the chat. You let me know when you want to end it.
Why don't we end it?
Okay, great.
Okay, so you're right. So the answer is definitely, it looks like, okay, so most people said, hold on 1 second. Really am having technical difficulty. Okay, so most people said C and some people said D. So let's talk about this, right? Let's talk about why and what. So C is the right answer. The issue with D is, and this is the most common mistake I see, and that's why I really wanted to show this. You carve out the rectum, right? The problem is if the rectum filling changes, that's because there is a little bit air in the rectum right now, right? If that air went away, what would happen? This would drop. The vagina would drop posteriorly, right? Even though you will add a PTV, you're right, it's a CTV, But if that air goes away, if the patient has diarrhea, right, that vagina could drop and you would miss the vagina. And that, I mean, this is probably one of the most common mistakes that I do see in contouring is carving out the rectum. Remember, you're only going to go to 45 gray. The rectum can tolerate 45 gray. So this is, and then yes, you do add a PTV, but that PTV may not cover it if that rectum is completely collapsed, or if the bladder is even a little bit full, right? Fuller than this, then it would drop. So that is actually why C is definitely the better answer than D. And I really wanted to show you this because this is really is one of the most common mistakes that we see in contouring. So let's go on to, I'm going to do all my questions first, okay? Just because I think it'll be interesting to do all my questions first and talk about contouring, and then we'll contour, okay? Okay, so let's go to the next question.
Okay, so next question.
Okay, so this is an interesting question. I'm actually asking you, this is an interesting question, and this is more about nodal contouring, even though we're not going to be talking about nodal contouring, but I do want to see, do you have this, the poll? Ah, perfect.
Yes.
But this is also relevant, right? When should you consider covering the sacral nodes in patients with endometrial cancer? Sorry, I don't know how I messed that up. In patients with endometrial cancer, all patients, patients with lower uterine segment involvement, patients with cervical stromal involvement, patients with serous histology. And this is also important. Even though it's a more of a nodal question, but it is also a very relevant question. This is an easy one though. Everybody should answer this one. And this is important because you do need to know what the nodal drainage is for your endometrial cancers. And again, I think we got about 76, so we're actually doing good. So let's end the poll.
Okay, great.
All right, so the answer is, and you guys are correct about this, is C. So 50% of you guys did say C. So the answer is C. And that's, so when, and this is important. So let's talk about that, right? Because we are actually going to do both endometrial and cervical cancer, right? So it is for cervical, if there's cervical involvement, they will be sacral nodal drainage, right? Endometrial cancer by itself does not go to the sacral nodes. As we mentioned, when it's endometrial cancer, I usually go cover S2. A lot of people don't even cover it down to S2. A lot of people don't cover the sacral nodes at all. But if there's any cervix involvement, or if it's post-op cervix, you do need to cover the sacral nodes at least to S2, if not S3. So that's actually a very important thing. So I'm going to ask a question, and I want an answer. If there is fundal involvement for endometrial cancer, besides the pelvic nodes, what's another node that could be possibly positive if there is fundal involvement? This is also very relevant when you guys are contouring. Any answers? And I can't, for some reason, see the chat, so somebody's going to have to help me here.
Okay.
Oops, sorry. I slipped it. Let me go back. Yeah. So, yeah, I can't see this chat, so you're going to have to help me with the chat. So any answers?
So the answers are coming in on the chat. So someone said pelvic nodes. Another answer is the para-aortic nodes. Yes, PA. Lots of PA's answers coming in.
And that's absolutely true. So if there is fundal involvement, the risk for a PA right underneath the renal vessels is going to be at a high risk. So great, you guys know this. Yay, good answer. All right, so like I said, we're going to go through all the questions first, and then we're going to go to contouring, okay? So the next question, and this is actually a question I'm asking because I want to know the answer, and you guys are actually going to help me. So this is actually a patient that I am contouring right now. And I want to hear what you have to say, and I'm going to let you know right now, there's one wrong answer, but there's no right answer, okay? There's one true wrong answer, but the other three are probably correct, okay? But I want to see what the answer is, and I am actually going to use your poll to help me treat this patient. So I have a 64-year-old patient, stage 3C1, low grade, grade 1 to 2, 96% myometrial invasion, 1 millimeter cervical stromal invasion. There is lymphovascular space invasion, but it's only 3 vessels, so it's focal, right? There is lower uterine involvement, so no fundal involvement, Okay, that's important. 5, so we do sentinel nodes, right? So we took 5 sentinel nodes out and we had 3 that had macromets of 3 millimeters and 1 micromet. So we're going to treat her because in my institution, we treat these patients with chemo RT followed by chemotherapy. And honest to God, this is a question. So what are you going to treat? What is the top of your field? S1, L5, L4, L5, top of L2, or top of the renal vessels? Oh, and people are already answering. Look at this.
Yes.
And actually, I'm being honest. This is a true patient, and I really want to see what your answer is because I may use it to see how I'm going to treat my patient. And I'll tell you what we kind of decided. Okay, so we have about 74. Yes. All right. So you guys, as I move to my next slide, I actually don't have an answer, right? I didn't answer this because as I said, there's one wrong answer and there's no right answer. So, but I'm going to share your results. So 56% said L4, L5. So 50% of you guys will treat the pelvis only, which I think is really interesting. The wrong answer is the top of L2. So I'm going to tell you the reason why that's the only wrong answer. And the reason why is top of L2, you're not covering all of the periodics. So if you are going to treat the periodics for endometrial cancer, you really need to go to the top of the renal vessels. Okay, so that's the only wrong answer. Otherwise, pretty much all the other answers, I think, really technically L4, L5 or the top of the renal vessels are probably the 2 right answers. And it is interesting, most of you guys would treat pelvis. I presented this to my colleagues because I didn't know what to do, right? Because she is at high risk for having periodics because she has positive pelvic nodes, right? But it is a low grade and it's only focal and vascular space invasion and it's lower uterine segment involvement, right? So 50% of my colleagues, all experts, right, and said extended field and 50% said pelvis. I talked to the gynonc and she's 50-50 too. I think I will treat her pelvis because it's a low grade and she's getting chemo, but we will have to watch her periodics very carefully. So good. I mean, this is great. Thank you. Any questions about this? I mean, it is a true case. I'm contouring it and presenting it. So I thought it'd be interesting for us to talk about it. So the next question, here's one, and this is a good case, again, where I see most of my mistakes coming from when I see contouring. What is the correct way to contour a vaginal ITV? A, B, C, or D? Ha! I thought we'd do questions first and then we go to contouring just so that we can, because I think the questions are actually bringing out all the issues of contouring in the first place, because you guys can watch me contour all you want, but I think this really answers your questions more about anything than anything else. And this could be either cervix or endometrial, but I can make it cervix and that would maybe make it easier, right? This is all post-op. People aren't as fast in answering these contouring questions as they are my other questions. Okay, we're right at
almost 70.
Yeah, so let's do that. Let's end it.
Okay.
So majority of you guys said D, so I agree. So you guys know what I'm talking about, right? Exactly. D is the right answer because we've already talked about not carving out the rectum, right? This is covering the rectum. The reason why this is wrong, but again, this is what I see as big mistakes when I'm reviewing charts for other physicians and even my residents, right? They missed, and I made it a little bit easier by showing you that there was, so this is, if you did one slice above, you probably would have missed it, but even the one slice above, you need to contour like this, right? Because this is your perimetrial nodes that are coming, not perimetrial vessels that are coming out, and they really should be covered as top of your vagina, okay? So that is still relevant in post-op patients. Okay, so even a slice above that, make sure you cover it. So good job. And again, one of the most common mistakes I see is that people miss this. And you can put it in 2 different ways. You can do it just like you did in the D, but if you do one slice above and you want to spare some of the midline structures, you can put it as a nodal contour, or you can just, and I'll show you, or you could just go right around this and do this and not worry about it, right? Okay, good. All right. I think this is my last question. And again, a huge mistake that I see when people are contouring. And this is the #1 mistake I see. What is the correct length of the vaginal ITV? And there really is a true answer. And this is, again, some of the biggest mistakes I see, and I see this all the time.
Okay.
Should we end it?
Yes, I think we're good to go.
Okay. So the answer is D. A majority of you guys just say C. And I'm going to tell you it is one of, what are you guys treating when you do C? Okay. This is a post-op endometrium. So there's like our cervix. It's all the same, right? I know, and my contours, I did this fast, so don't look at my vaginal contours, but it's the length of the vagina, right? And so here we know on this one, we are definitely going all the way to the anus and treating the vulva, right? So we know this is long. So we already know this, and this is too short, right? But even here, you are pretty much at the urethra, and you are treating the entire vagina. So unless there's a risk, and this is a great reason if you had a patient who had recurrent endometrial cancer toward the vagina, or if you're treating for vaginal cancer, this is a great contour. So you want to go to the urethra, right? But for post-op, you don't need to, unless there's major risk factors, you do not need to treat the entire vagina. There is no reason to treat the entire vagina. And what the answer is, and this is why this one I know is really you do to mid-symphysis, and you're still going to have a 7 millimeter. So this may be even a little bit too long for the CTV because you're going to have a 7 millimeter PTV to it, right? But here, you are up to the urethra, you are treating the entire vagina. And there's no reason, unless there's risk factors, to treat the entire vagina. So does anybody have any questions about that?
You can ask your questions on the chat, or you can just open your mic if you have any question on this case. Because I think a lot of us, I thought it was answer C too. So I think it is a common mistake we do. So if you have any question.
No questions? Wow. Okay,
people
are quiet.
Yes, we have a question. Does it change even if there is cervical invasion?
Yeah, no, it doesn't change. Cervix invasion makes no difference, right? That's not a risk factor to include the whole vagina, right? There's no reason to treat more than 3 to 4 cms of the vagina, unless there's other risk factors like vaginal involvement. So when would you suggest? Yeah, if there's vaginal involvement, if it's recurrent endometrial cancer to the vagina, those are really the only reasons why I would treat the whole vagina. Okay, do you put a vaginal marker? So I don't, and so that's a very good question. And you can see most of my CT scans, I don't have a vaginal marker. I don't put it. Some people do put vaginal markers. In the old days, when prior to us doing CT sims, we would put fiducials and into the vaginal apex. I don't do that anymore. There's multiple reasons why we don't do that. I don't think you need it if you're using CT scan to plan, but there's nothing wrong with it. But if you do put a marker, you need to be very careful that you don't push and put a lot of pressure into the vagina and make it peak up. So that's a very good question. Okay, I'm going to stop sharing for 1 second, and then I'm going to start sharing again. So give me 1 second. I am having technical difficulties, which I don't normally have because I'm a Zoom expert. Okay, so let's start. And I'm going to let you watch the chat while I contour. So this is a patient, again, with any post-op patient, we will do an empty and full. So this patient also has an empty and full, as you can see. It's not quite as empty as you would like, but it's an empty and full. It is a patient that I've actually already contoured before, but we're gonna start contouring. So where do we start? And again, vaginal markers are great. They really do help if you want to put it, but you just got to be careful about how you put it, and make sure that you don't use that because it could slip. It could do anything. So you got to make sure you still look at your anatomy as you're contouring, okay? So in this case, this is a tough case. And in fact, we'll see how I contour it again, right? It is a very tough case because she has a lot of bowel. And even with the empty and full, she has a lot of bowel. So the question is, how do I contour it? This is actually a good case for me to show you because I did have a tough time contouring it from the beginning. So because some of this right here is bowel. So it's not, and that's where in this case, a vaginal marker would be actually very beneficial because it may show you the top of the vagina without having to go scrolling in and out. Okay, but I had to scroll in and out. See, this is all bowel right here. So I know that this is probably bowel right here. So the question is, where does my vagina, where does the vagina start? And this is where you can also look at your sagittal, and that really does help because what you can start contouring, but you want to look at your sagittal and see what do you see in your sagittal, because the sagittal will also tell you where the top of the vagina is. So you could even contour it a little bit and then come back and see, is it bowel or is it vagina? So what I did, and like I said, this was a tough one for me. And this is actually one of these cases that we use as experts to contour. So I actually did start off, and it's the same color as the bladder. So I'm gonna take the bladder off for a minute. So I actually did start off by going lower and then going up. And you can do it however you want, but that's how I started off on this one because it was hard for me to figure out where the top of the vagina was. But so this part I know is the vagina. So I'm gonna go here and I'm gonna make sure I'm covering it both in the empty and full. And you can see that she actually has a lot of gas in her empty. So it is pushing it into the bladder. But so that is, and I'm gonna cover my perimetrium, right? And I'm gonna cover posteriorly. And again, I'm not carving out of the rectum. And I'm gonna do there. So now we're gonna go a little bit lower and I'm gonna slip slices. Again, I know this is vagina, right?
Dr. Jhingran, while you contour, there are a few questions, so you can try to answer while you contour. So one of them is, do you spare your urethra in your CTV? That's one question. And the other one is the length you use from the apex to the CTV.
Right. So again, good questions. All those are very good questions. So remember, we talked about the urethra is really the urethra. The urethra meatus is going to be your inferior extent of the vagina. So if you are going to treat the entire vagina, then yes, if you're going to treat the entire vagina, then you're going to go to the urethra and then you should spare it. In most post-op endometrial and cervix cancers, you don't treat the entire vagina, so you should not be near the urethra. We normally you have to treat at least 3 cms of the vagina in the post-op setting. I tend to treat about 4 cms of the vagina in the post-op setting. So my CTV is about 4 cms, and then I put my 7mm PTV, so it's closer to 4.5 to 7. I usually go right to the mid-symphysis. Now this lady, you can see probably has a very short vagina, but I usually go right about to here. This is probably the lowest I'm gonna go. This probably was a little bit lower than I would probably go. And this is probably my last slide. So I go right to the mid-symphysis, but I do treat about 100% treat 4 cms of the vagina. But the answer is between 3 and 4. Nobody really knows quite, but you do not need to treat any more than that.
Okay.
Okay, so that's going to be my lower extent. So now I really got to figure out where is my top, right? And we talked about this. And this is, like I said, this is hard because I know that this is bowel. So what I did come back and I did was I actually, and if you saw this, I know it's going to be my perimetrium, right? But this is after I went and scrolled up and down a lot. So this is where that vaginal marker does help. Okay, because it will tell you where that top of the vagina is. But in this case, I actually had to scroll up and down. So I'm going to put this as my vaginal ITV covering the perimetria. Okay, now you could do as your nodal contour because this is all bowel right here. So I don't need to go midline there. So then the question is, where do I start? And I probably would have started right here. as my true ITV. But this requires scrolling up and down and looking at my sagittal. So if we look, did I really do that? So let's see if we did. I mean, that's how I actually, and this is what, I did this before, and I actually changed it multiple times because this is a hard case. So I actually went even lower on this case, right? And I actually went higher on my ITV. But if I was doing it again, this is how I would do the yellow instead of the red. Because this is all bowel. So here I would actually, there's a little bit of perimetrium still left here. So I would add perimetrium right here. And I would not put that as my midline structure there. And then down. And then here I probably would go, then yeah, see, I did the mistake. I carved out the rectum there, right? So there you go. And that would be, and if you look at my sagittal, I'm a little bit there, but as you can see, I'm mid-symphysis. As I said, I just stop, and if we measure this, it's right through 4 cms. Look at that. I mean, all I'm supposed to do is show you the vagina and post-op. So this is good. This is an easy thing. It's the cervix and endometrium is all the same. You treat about 4 cms. I'll be on, really. And if you looked, and I said it is right at the mid-symphysis where you stop, and that's going to be right at 4 cms.
What is the superior border for parametrium that you would contour?
So I look, and it's the same thing as it's the same thing as your cervix, right? So it's going to be exactly, so it's where you see those vessels. And I would either include that in my perimetrium, or I would have included this in my nodal. It probably would have gone into my nodal. So next slice, I would probably include that in my nodes, which is probably where I did include it. Questions? This is an easy one, I know. So this is my nodes right here. And as we go down, and these are nodes that I had contoured earlier. And you can see I included, so you can see where I did go more midline to make sure that I cover the perimetrium. And I probably went a little bit more midline than I wouldn't have, see if I have to do it again. Like I said, you have to realize that you really do need to look at this. I think we went way.
We have a great question in the chat, yeah. Dr. Jhingran. And yes. Is it like in this case, you mentioned that the images of the full and empty bladder are nearly similar. So can you reduce the margin you give anteriorly or posteriorly to the ITV?
Yes. 100%. So in this case, and you know what? I wonder oh, this is the PTV. That's why you were looking at. I'm sorry. So that was what the problem was. I was trying to figure out why. So there's my, I was wondering why so this is the PTV. So let's not look at the PTV. Sorry. So so you can see where I did it before. Yes, you can definitely make the margins less because there's not much difference between the bladder and the rectum. I mean, between the bladder and the movement of the vagina. So then you can definitely make it less. I was trying to figure out why I had it like that. So here we go. Okay, I did it. I knew I didn't make those mistakes, and I was trying to figure out what I was doing. That was the PTV. So this was my original contours, but you can see where I do even with my nodal CTV go a little bit more medial to make sure I'm covering the perimetrium there. So you can see that, and then as I go down, and then I had the vaginal contour there, but yes, you can definitely make it less. Other questions?
Do you do daily beam CT for your post-op endometrial cancer?
I don't. Because I do an ITV, I don't. I actually don't. But we do bladder scanning. So we do make sure that the bladder is as full as it's supposed to be because it does push. And if you look, even in this case, and you can see here's the bladder that's pretty full. And it does push the bowel out of your field. So, having that bladder full really does make a difference on how much bowel you're going to be treating.
Great tip. There's another question on the chat. So for presacral nodes, do you still use S2, S3, or piriformis as a landmark? Does it differ if there's intact cervix versus post-op?
Right. So all good questions. I'm going to actually stop sharing. Okay. So I can see this. Okay.
Okay.
So they're actually, even in Embrace, they are using bony landmark for your sacral nodes. So even in the Embrace protocol, they're not using the piriformis as your landmark. So Embrace says S2 for intact cervix. We always go to S3 for intact cervix. We also go to the bottom of S3 for post-op cervix. When actually it's really, it's really your PTV should be at the bottom of S3 for both intact and post-op cervix. So your CTV probably is stopping like mid-sacrum. For endometrial, it's really, sacral nodes are not going to be involved. We always go, our CTV goes to mid S2, so our PTV goes to the bottom of S2. So that's the one place, even in Embrace, they're actually using bony landmarks and not the piriformis. How do you determine to contour post-op cervix? So the question is, who do I treat for post-op cervix? I mean, post-op endometrium? That's the question, right? My post-op endometriums who get pelvic radiation are mainly stage 3s, Cs. All my 1Bs, unless it's grade 3, get cuff. If it is a 1B grade 3, we may do pelvic radiation, we may do cuff, it varies. But we are still, for all our stage 3 Cs, we are still doing chemo RT followed by chemo because our gynecologists, besides Ceres, our gynecologists really believe in radiation still and do believe in the PROTECT study over the GOG study. But it varies, right? So we do chemo RT followed by chemo. A lot of people will do chemo and then add radiation at the end. I don't think either or is wrong. So we do a lot of post-op, like I showed you that one patient. We do sentinel nodes here. So we see a lot of stage 3s more because of the sentinel nodes. And so we do treat a lot of post-op endometriomes. Yeah. So the next question is, how often do you do cone beams during treatment? We do it once a week, unless there's issues. If there's issues, then we'll do it every day. If there's a lot of change in my ITV between my empty and full, I may do it daily. If there's not, or if there's a lot of gas in my rectum, right, and or stool, and I couldn't get it out, then I may do it even every other day. You definitely, if there's a lot of stool or gas in your rectum and you just really can't make that go away, the first 3 weeks are going to be constipated because of the surgery. We will start doing more frequent CBCTs in the 4th and 5th week when they have the diarrhea and they can't get their bladder full. So we may change it depending on the week. We usually start off with once a week, but we may change it to more depending on their symptoms.
So I do have a few questions. So sometimes when you go through gene cancer, there are 2 options for the pelvis. You either can do 45 or 50.4 grade, right? It's like this range you have. So when would you choose to give 50 and not 45?
So that's a good question. And there's no right answer to that either. Okay, so can I say that nobody knows what the right answer is. We always give 45 and we always do vaginal cuff boost. So we always give 45 and we do 2 vaginal cuff boosts at 500 times 2 to the surface. That's our standard.
Okay.
It gives less dose to the bowel, and we're also giving a boost to the area that still has the highest risk of recurrence, which is, especially for endometrium, right? Which is the vaginal cuff, right?
Right.
So, right, so that's our standard. It's the standard same for cervix, which in my mind, that doesn't make as much sense. because you're taking more of the vagina out when you do the cervix. So do you really need to do the vaginal cuff boost? But that is our standard for all post-op patients. So it's 45 and it's 2 vaginal cuffs. Okay. I do believe if you're not doing the vaginal cuff, then 50.4, because that's what was used in all the protocols, is probably the right answer. But it is a higher dose to the bowel, right? Yes. So, but you know, that's what's been used in the protocols. And so that's what you probably should do. But like I said, we always do 45 and we always do 2 cuffs. I mean, that's just our standard for post-op patients.
Even if the patient doesn't have cervical stromal invasion under pathology?
Right. Right. Because you know what? Look, aren't you, I mean, you're 1Bs that have no cervical stromal invasion, right? You're doing cuff. Why are you doing cuff? Because you think that patient's going to recur in the vagina, right? So why not give something that's easy? Because we prescribe it to the surface. So we always prescribe it to the surface, right? So why not give an extra dose that's free to the vagina? It is free, right? And you're giving less dose to the bowel. Because still, right, the highest area of recurrence is going to be in the vagina. Does that make sense?
Yes, it does, because Fortec established this 73% that you go and learn by memory. So 73% of patients recur in the vaginal cuff. So yes.
Yeah. So you're giving, but it's important to know what I'm giving, because that's what I've seen is people give 45 gray and then they come back and give the full dose, right? They give 7 gray times 3 to the vagina. And that you should not do, because then you're giving a way too high dose of the vagina, and then you will cause toxicity to the vagina, which isn't free. You will definitely cause. So we do a lot. So we do 45, and then we give 5 gray times 2 to the surface. Or if you think there's a little bit higher risk, especially if there's cervical stromal involvement, you can do 6 gray times 2 to the surface.
Okay. Really interesting.
But it's important.
Another question on the chat that I would like to make. So do you use a 7mm margin all throughout from your CTV to PTV, or use 15mm, 10mm, 7mm?
No. We always, that's different, because those different margins are actually for intact cervix. We use 7mm for everything. For everything.
What type of brachytherapy are you using in the post-op endometrial cancer?
Yeah, it's the same thing. So you know what? And again, there's no right or wrong answer to this. So I do need you guys to know, in the old days, we used to use ovoids, right? Now we use cylinders because they're easy, right? You put a dome and 2 cylinders in. Again, though, it's so important. So let's talk about that, because this is the other mistake I see, right? You don't treat the whole vagina with your brachytherapy. And the ABS guidelines really is 3 to 5 cms, and that's all you need to treat. We treat 3 cms no matter what. We don't ever treat more than 3 cms unless it's recurrent. But the recommendation is 3 to 5. Do not treat the whole vagina. Even if you're doing it with external beam, do not treat the whole vagina. So yes, so there's 2 questions here, and so yes. So let me answer, because I'm going to answer the second question, but I did answer one, and I'm going to answer this question. Yes, you definitely give higher dose if there's a vault recurrence. Okay, that's a whole different thing, right? When I'm talking about the 45 gray plus 500 times 2, that's for prophylactic, right? That's for patients that you're treating upfront post-op, right? Straightforward. If I have a patient who has recurrent disease to the vaginal apex, small disease, I give 45 gray to the vagina, and yes, I give a higher dose with my cylinder. You can do 7 gray times 3. We tend to do more. We do tend to go a little bit slower, but you have to look at your EQD2 on that. This is where then you look at your EQD2, and you look at your dose to your bladder and your rectum. We usually do again, We can, because our patients can come backwards and forwards. So 7th grade times 3 is fine. We tend to do like 5.5 to 6th grade times 5. We like to try to get an equivalent of 75 to 80 gray to the vaginal apex if that's where the recurrence is. But there is nothing wrong with 7th grade times 3. But again, look at your EQD2. What you want to do is you want to get that dose, and you want to get about 75 to 80 gray. If it's minimal disease to vaginal apex, that's the dose you want to give. So look at that. It usually comes out to about 5.5 times 5 or 6th grade times 5. But look at it and get that dose. So correct, 2 different scenarios. So I am not talking about, when I'm talking about that 45 gray times 45 gray plus 2 is prophylactic. 100% you give higher dose if you have recurrent disease. So what's the minimal time you know what? Good question. I actually, most of my endometrial cancer patients, or even my cervix cancer patient, but we're talking about endometrium because that's really what I mostly see, because my cervix patients usually are intact. I don't see very many post-op cervix, but either way, I sometimes will, most of them are from out of town. So a lot of times what I'll do is do the external beam in the morning, and I do my vaginal cuff in the afternoon, 6 hours afterwards, and I try to finish everything in 25 days. Nice. But you can also do it 45, 25 fractions and do the vaginal cuff back to, one day and next day. If I'm doing vaginal cuff alone, we do 6th grade times 5, and we don't do all 5 fractions in 1 week. We like to do a break. So, the standard is every other day, but a lot of times what I'll do, again, because my patients come from out of town, you want to do, I can do Wednesday, Thursday, Friday. As long as I'm giving Saturday, Sunday off, I do Monday, Tuesday. But I will never do 5 vaginal cuffs at the same week if I'm doing prophylactic. If it's recurrent disease, I will do it back to back to back to back. Recurrences can go higher than 75 to 80. It depends on how big your recurrence is, right? So what the surface dose I was talking about is somebody who has 5 millimeters or less vaginal recurrence to the apex, and you're going to treat with just cylinder alone. You probably can give about, you probably don't need to go higher than 80 because you have minimal disease. And we don't. If I'm going to do cylinders alone, and it's minimal disease, 80 probably is the highest I go to. And we have great local control. But if you can push it, you can push it. But we don't tend to go higher than 80, and we have no recurrences. Ooh, a lot of questions here. Okay, yeah. Positive margins. So let's talk about positive margins. Okay, that I didn't talk about. So let's talk about positive margins. So no. No. So let's talk about positive vaginal margin, because that's a whole different scenario. Okay. You got to find out where your margin is positive. Now, if it's vaginal cuff, then I think you have to go to a higher dose. Majority of the time, say it's cervix cancer, because that's where you're going to see most of your positive margins, right? Your positive margin post-op cervix, which we see a lot, is usually not in the vagina, and it's usually right next to the bladder, or it's right next to the rectum where you're going to see the positive margin. So this is where your vaginal cylinder will not treat, right? It's too deep. So we tend to use external beam boost, because your cylinder is not going to hit it. If I have close margin, what I will do is take the upper vagina and the perimetrium where there's positive margin to about 56, and I do 1 cylinder. If it's positive margin, we take that whole area to 60. And it's just the upper vagina and the perimetrium. Now, if you have a vaginal cuff margin that's positive, totally different, then yes, you can boost with the cylinder. But you've got to know where that margin is positive. I hope that makes sense to everybody. the recurrences, and you got to know what the size of your recurrence is on the dose. So I was really talking about somebody who had minimal recurrence, because you're right. If you have more bulky disease, you're going to a higher EQD2 dose, but then you're not going to use a cylinder because the cylinder is not going to cover it. Then you got to put needles in. So we really don't see much radiation cystitis and proctitis in post-op patients, because we're not going. One, we treat all our vaginal cups to the surface, and we do stop at 45, and then we do the 2 vaginal cups. So in our post-op patients, we hardly see any cystitis or proctitis because of the dose that we give. For my medically inoperable endometriums, grade 2 or higher, we always do external beam, and we do brachytherapy, right? If it is a grade 1, minimally invasive, you can just treat with brachytherapy alone, but anything above grade 1 will have nodal risk, and so you do have to do external beam, and then you do the brachytherapy. We use the dome. I had a picture somewhere. I found it. But we use the dome, right? And then the 2 cylinders, but you're treating the dome. Do you know what that dome looks like? Because I mean, I can show it. Does everybody know what that looks like? Oh, do y'all have a dome? You have a dome, right?
I'm not sure. If you want to show us, I think it will be great.
Okay. While I'm pulling that up, you want to look at the chat and tell me some other questions?
No, we're good. Those were the last ones. But great questions, everyone. Lots of questions.
Yeah, questions. This is good because I didn't have that much to show you because it's not that hard. All I had to do was show you how to contour a vagina, which y'all already know how to do. Okay. I don't know if I have a picture of a dome. Let me see if I have it. It's interesting. I would think y'all would know what that looks like. Other questions while I'm pulling it up?
We are good.
Wow. Sorry about that. Let me see. Oh, here we go. Okay, I'm going to share again. I don't know why I'm having technical difficulties today. Okay, so see this? Can y'all see that? So this is a dome, right? So it's conical. Now, so what it is the top part's a dome, and then you got the 2 cylinders. But this is all we treat of the vagina.
3 cm, right?
This is, 3 cms. We only treat 3 cms. ABS is between 3 to 5. I always only treat 3. And I have actually had no recurrences. And we've actually have published our data, and we're actually going to publish an updated data on that.
Dr.
But that's
Jhingran,
what it is. Yeah.
Do you prescribe it at the surface, or do you use 0.5 centimeters?
No, surface. We always prescribe. So we do 6 gray times 5 to the surface.
Okay, to the surface.
Yes, to the surface.
Okay. I like the question about toxicity, because last time we also had questions on toxicity. And for me, there is something with endometrial cancer that I think is really important, is the use of vaginal dilators. So we recommend it. All your endometrial.
We do. We actually do. We actually give it, unless they're like 70 or 80 years old and there's a reason, we give all of our, even if all we're doing is doing cuff, we give them dilators. And because it does make a difference, because they will, I mean, the one thing that has been noted with vaginal cuff is that it does, you're giving a higher dose to the vagina, there is a risk of scarring, and it does affect pelvic, exams. So we always give dilators to all of our endometrial cancer patients and tell them to use it twice a week. Always.